Hello, everyone. We are back today. We are talking quite a sensitive and very common condition. We are talking about Polycystic Ovarian Syndrome, what people commonly call PCOS. Once again, I'm Dr. Muhamza Joseph. I'm an obstetrician and gynecologist. I'm also a fertility specialist. With me, we have a very highly skilled guest with us, Dr. Anthony Kaira. Please introduce yourself.
So I am Dr. Anthony Kaira, a reproductive endocrinologist and infertility specialist from LifeSure Fertility and Gynecology Center.
Your messages on the platform have been very insightful.
Thank you.
The viewers are pleased, and we are also pleased to have you.
I'm happy to contribute to the channel.
So, straight from the top, what is Polycystic Ovarian Syndrome?
Polycystic ovarian syndrome is a hormonal condition among women of reproductive age, which is mainly characterized by rarely having periods or not having periods at all, despite having started having your periods at the beginning of your puberty. Another characterization is they tend to also have, some of these women will have a male pattern distribution of facial and body hair. When I mean by male pattern, like appearance of a predominant mustache or a chin hair or sideburns or chest hair. Some may report significant difficulty with pimples or acne, despite having completed their puberty.
Yes.
And many of these women will also report challenges conceiving. For some of these women who eventually do a scan, an ultrasound scan of the pelvis, they usually report that there are small cysts in their ovaries. From that is where we get the name Polycystic Ovarian Syndrome.
Okay. So, what causes the condition? What causes it, and what are the risk factors?
So Polycystic Ovarian Syndrome, what the current evidence shows, and there's a lot of research still going into it, is that there is a genetic condition or some kind of genetic problem or abnormality in the genes responsible for metabolism. And you find that insulin is not being operating normally. The role of insulin is to move glucose into the cells.
Yes.
And in this kind of patients, we find that insulin is kind of not doing its work well at the cells. And so the body responds by producing more insulin to try and override that problem at the cells. Instead, that causes the ovaries to malfunction. The high insulin levels in blood cause the ovaries to malfunction. When the ovaries malfunction, they present by rarely having periods, high production of male hormones, and subsequently, of course, failure to conceive, since you rarely are ovulating.
Okay.
Yes.
Okay, so it's more to do with a little bit of insulin resistance and all.
Yes.
All right. So you've talked of Polycystic Ovarian Syndrome causing delay to conceive. How common is the condition in the general population?
In the general population, what the research shows is that 1 in 10 women are likely to have Polycystic Ovarian Syndrome. But if you pull together a population of women who have challenges with periods, for example, rarely having periods or not having periods at all despite having started at puberty, then the number can go to as high as 6 to 7 out of 10 of these women who report with challenges having periods are likely to have Polycystic Ovarian Syndrome. So it's quite common among that group.
That's a quite big prevalence.
Yes.
Okay. So what is its impact on fertility? Why do the women not conceive?
So in a typical couple, the chance of conception is mainly governed by ability to predict when ovulation has happened. That's why we have all these methods where we attempt to predict the fertile window, looking at cervical, vaginal secretions, looking at body temperature. There are several strips available to detect if ovulation has happened. So when ovulation rarely happens, like in the patient who has, or the woman who has PCOS, it's very difficult for the couple to predict when to have sex, how often to have sex in this period. So if you can't know the fertile window, it's hard to know when to actually meet and attempt to conceive. And that significantly delays some of them usually have children, like one child, but they will tell you we struggled. Took 2-3 years to get that one child, and we're now here because the second child is not coming any sooner.
Yes.
And it's just the difficulty predicting ovulation in these particular cases that makes it hard to be able to get pregnant.
Okay. So you've talked of an ultrasound scan and cysts that appear on the ultrasound scan. Is the ultrasound scan enough to diagnose the condition?
An ultrasound scan is not enough. You need a woman presenting or someone out there who has challenges having periods. For example, you miss 1 month, 2 months, 3 months, sometimes up to 6 months or even a year for some. And then you either have the cysts on an ultrasound scan or you have appearance of either acne or significant burden of pimples despite having gone through puberty, or having a male pattern of distribution of facial hair. That is the mustache, chin hair, sideburns, or chest hair. So either you have, so the most important thing is that you have a missing of periods.
Yes.
And then you either have an ultrasound scan showing that the ovaries are polycystic or have multiple cysts, or you have the clinical presentation of male pattern distribution of hair. But in the clinic, the doctors can also run some lab tests to look at the male pattern distribution of hormones in your blood. Yeah.
Thank you very much, Doc. So apart from it affecting fertility, what are the long-term complications of this disease?
Apart from fertility, we also have an increased risk of developing diabetes. That is a condition where you have inability to utilize insulin. And we already said earlier on that insulin resistance is part of the backbone of how this condition presents. Yes. We also have an increased risk of developing hypertension or cardiac diseases, which are more, say, related to having diabetes. And then we have an increased risk of having endometrial cancer. How does endometrial cancer come about? The more times you miss ovulation, the more the endometrium or the lining of the womb is exposed to unopposed estrogen, which is the hormone that grows the lining of the womb. And the longer it is, which would happen in a patient with polycystic ovarian syndrome, who is not appropriately managed, the higher the risk that at one point in time, in that overgrown lining of the womb, there might be a rise of endometrial cancer. Yes.
Wow, quite a number of complications with the disease.
Yeah.
So, what are the common treatment goals and options?
So since it has been established that the backbone of onset of polycystic ovarian syndrome, or how it actually is conducted in the body, is insulin resistance.
Yes.
The best thing is to improve insulin sensitivity. So how do you improve insulin sensitivity? First things is exercise and diet. So exercise is part of lifestyle modification, where you increase physical activity, reduce sedentary activity or sitting or inactivity, and also improve your diet by reducing the amount of processed carbohydrate. Things like cakes, sweets, white bread, rice, posho, processed carbohydrates, that they really are kind of a negative towards improving insulin sensitivity. The second thing is there are drugs that promote insulin sensitivity, such as myoinositol. Myoinositol is a drug that kind of mimics what your body does, because myoinositol itself is a carbohydrate that your body uses to improve insulin conduction in your cells. So when you provide it as a supplement, you improve insulin sensitivity, you reduce insulin levels in blood, which improves ovarian function, and then spontaneous ovulation will start. And then the chance of having menstrual cycles that are regular will proceed. And then chance of predicting a pregnancy will follow then after.
Okay. So, myoinositol, lifestyle modification.
Yes.
Anything extra in terms of the drugs?
Yeah, so there's also use of metformin.
Okay.
So metformin and myoinositol kind of carry the same benefit, but myoinositol is more tolerable at the doses required to have any effect. The doses required for metformin to have effect are associated with significant side effects like nausea, bloating, vomiting, fatigue, whereas the doses required to have effect with myoinositol are quite more tolerable. So myoinositol is preferred compared to metformin. Yes.
Okay. I've encountered a number of patients with polycystic ovarian syndrome being managed with oral contraceptives. Do they play any role?
The notion behind using oral contraceptives is to try and reset the pituitary.
Okay.
So the pituitary is a master gland in our body, just behind our eyes, that controls the function of all other hormones in our body. And one of the theories of onset of polycystic ovarian syndrome is the fact that there's an abnormality at the pituitary or at the master gland, and that combined oral contraceptives can reset. But the combined oral contraceptives cannot do that, because when you stop taking them, the pill, usually the patients will report, I'm missing my periods again. So the reset is actually something that is a fallacy. I don't think it can really happen. So the only reason you would provide combined oral contraceptives is they actually have a benefit in reducing acne. They have a benefit in reducing acne or those pimples that are quite burdensome to some of these patients.
Wow.
But as a way of reversing the condition or correcting it, highly unlikely, because it's a genetic condition. So the lifestyle modification, the myoinositol or metformin is where you can actually optimize the condition for the benefit of the patient. And also the fact that most of these clients want to have kids. And contraceptives, of course, are contraceptives and birth control. So it would be quite unintuitive to give someone contraceptives when they have missed periods or menstrual cycles.
Okay, that makes a lot of sense, Doc. So you've talked of myoinostal. There's a lot of myoinostal on the market, different forms of the drug. And personally, what I've seen is patients, especially those who want fertility, benefits from the disease. Treatment with myoinostal has shown to provide very, very good outcomes.
True.
What's the dosage? How do you take it?
So there are very many formulations, but the formulation that I and you are familiar with is the one from Wholesome Story, myoinositol coupled with the chiroinositol. And we do about 2 to 4 grams, starting at 2 grams and moving our way up to 4 grams. So with the Wholesome Story myoinositol, that is about, with 2 grams, that's about 4 pills a day. And with 4 grams, that's about 8 pills a day. Of course, your doctor will see how to step up or step down, depending on how you're responding.
Any side effects from the inostal?
Of course, some people report some nausea or flatulence or bloating, but as I say, these symptoms are very, very rare in the effective doses of myoinositol compared to the effective doses of metformin.
So the wholesome story, myoinostal, personally, I've used all kinds of inostals, but this inostal has really surprised me.
That's true.
Because most of the time you give the inostal and then you think maybe at the end of the day you still have to do some ovulation induction.
Yeah, that's right.
But I'm quite surprised that most of the patients come back pregnant.
Yeah, that's very true.
Even before you think of doing the ovulation induction.
I've had the same experience with Wholesome
us.
Stories, myoinositol. Many of the times I have rarely prescribed more than 3 months before someone comes with a pregnancy test that is positive. So I find that as much as there are many brands out there on the market, my and your personal experience with this is Wholesome Story, myoinositol is where we recommend it. Because there are many brands, I've tried using many brands, I've had very mixed results, but with the Wholesome Story myoinositol, I am having consistent results, at least in those who clearly will benefit from it. Like, for example, onset of regular cycles. 1-2 months of prescription cycles are regular. And in case they're looking to conceive, they'll conceive immediately. Indeed, what I've tried to do is bridge the myoinosital with exercise and diet, because it takes people some good time to build up a habit on exercise and diet. So as they're trying to build up that exercise and diet habit, they're taking the myo, the periods are regular, and many times they actually eventually discontinue the myoinosital, and they continue with exercise and diet, and they're able to have their regular cycles and conceive.
Great. So one more thing is polycystic ovarian syndrome. Is it curable?
Polycystic ovarian syndrome is not curable.
Okay.
It is something that happens within the genes or building blocks of our body that eventually gets unmasked as we grow because of maybe an environmental exposure, but it can be managed. And you can live a very wonderful, productive, optimal, healthy life. Okay. If you do identify yourself, seek the appropriate healthcare providers consult, know what you need to do and what you don't need to do, take your meds, modify your lifestyle. It's actually manageable.
So personally, most of my polycystic ovarian syndrome patients, definitely the majority of them come to me when they want to achieve fertility plans. And most of the time the prescription is wholesome myoinostal. How easy is it to get this product?
Wholesome myoinostal is available on order. So if you can follow the links to the channel or this podcast today, you'll find the numbers you need to WhatsApp or text or order, and they can deliver to you at any location where you are with the appropriate prescription. Yes. But don't forget, it's good to seek medical advice before you start myoinostal, so you know that you actually have polycystic ovarian syndrome and not some other condition that is causing you to have challenges having your period.
That's very important, because you don't want to concentrate on the polycystic ovarian syndrome and then the tubes are blocked.
True.
Yes. Thank you, Doc. So, in conclusion, what's your concluding message in regards to PCOS?
Polycystic ovarian syndrome is very common. Okay. And many people out there have challenges with periods, but they probably do not know that they could have polycystic ovarian syndrome. So if you're out there and you rarely have your periods or you miss your periods, please seek the attention of a physician who is very has expertise in reproductive endocrinology that can diagnose and confirm that you have polycystic ovarian syndrome, because it can be managed and you can achieve an optimal, healthy, fertile, productive life.
Okay. Maybe one more last question, Doc. So polycystic ovarian syndrome, we can see you can achieve fertility plans through natural conception. Are there other options in terms of fertility treatments?
Yeah, there are a multitude of options in terms of fertility treatment. If natural conception, which is the first line, fails, there are certain procedures that your doctor can do to improve on the insulin sensitivity. You can also have what we call ovulation induction. These are like boosting drugs that are given to you to increase the chance that your body is able to override that restriction and have ovulation and then probably chance at conception. And if all fails, in a small percentage of people with polycystic ovarian syndrome, all those that have an additional problem, either you have an issue with ovulation and an issue with your tubes or an issue with your male partner's sperm, usually end up doing an IVF or in vitro fertilization. But personally, exercise, diet, myoinostal will resolve almost 80 to 90% of patients' issues with ovulation, as long as there are no other factors that are hindering conception.
Yes. Okay. Thank you. So recently, anti-Mullerian hormone has been introduced as among some of the criteria for diagnosis of this condition. What's your experience with the levels of anti-Mullerian hormone people who have polycystic ovarian syndrome?
So anti-Mullerian hormone is a hormone used to kind of predict functional ovarian reserve, how many eggs are available that could be going into the next cycle or the another cycle or the other cycle. And as we've seen that these patients who have polycystic ovarian syndrome have challenges ovulating. So they have like some kind of arrest. The eggs are locked in somewhere and they're not moving forward. And they usually have a very high anti-menstrual hormone level, usually probably high above 3.5, depending on the reference ranges of the laboratory that you're using. And that alone can be an unequivocal marker that this is polycystic ovarian syndrome. So if your doctor does order an anti-menstrual hormone test, they're trying to see, does your ovarian reserve indicate that you have polycystic ovarian syndrome or not?
So at the extreme end of polycystic ovarian syndrome, we have another condition that can almost present the same way, especially in regards to menstrual irregularities.
So we have two conditions actually.
Yes.
We have hyperprolactinemia.
Yes. And
then we have hypothyroidism. Yes. So hyperprolactinemia is just close to the gland I told you, the master gland. There is cells that produce the breastfeeding hormone. So in women who are lactating or breastfeeding, they produce plenty of this hormone to produce breast milk. Unfortunately, that is the hormone that is actually responsible for why breastfeeding mothers don't have menses and do not get pregnant. So if for some reason, either because of a drug you are taking, stress, some other reason, that hormone is high when you're not pregnant, it will also cause you not to have periods. But uniquely, people with high levels of prolactin will also have a secretion from their nipples on their breast. So when you have that, then likely chance, they're like it's not polycystic ovarian syndrome. But as I say, this is a very small percentage of people among those who are missing periods. The second one is thyroid dysfunction or thyroid disease. And more commonly when you have very low levels of the thyroid hormones. The thyroid is a gland right in your neck that is responsible for controlling, again, metabolism in your blood and in your body. And once it has very low function or high function, it kind of interacts with the master gland and can affect how your cycles are regular. So most commonly when those levels from your thyroid gland, which is right in your neck, are very low, you have challenges with missing periods and conceiving. But this is still a very small percentage of people who have irregular periods. The biggest number is still polycystic ovarian syndrome. But your doctor will try and rule out the other causes. That is why it is important before you embark on any kind of medication or convince yourself that you have this condition to seek medical advice from an appropriate physician who has expertise in reproductive endocrinology.
Thank you, Doc.
Yes.
So, as we conclude about today's discussion, polycystic ovarian syndrome, well, we've looked at almost everything. Presents with irregular periods, delayed to conceive, some male features here and there. It's a manageable condition. It's not curable, but it's manageable. And usually I think the management is tailored according to this person's goals. If they want to see their periods, that's treatable. If they want to lose the androgenic features, if they want to conceive, all that is treatable. So if you're out there with polycystic ovarian syndrome, just know whatever it is causing you can be managed. Thank you for watching. Thank you, Dr. Anthony.
Thank you for having me on the podcast.
Thank you.